Withdrawal is the body and mind's reaction after reducing or stopping a substance or behavior that has become relied upon. It can show up as physical symptoms like sweating, nausea, tremors, and disrupted sleep, and as psychological symptoms such as anxiety, irritability, depression, or intense cravings. The severity and duration depend on the substance, length of use, dose, and individual factors like genetics, mental health, and physical condition. Withdrawal is not simply willpower failing. It is a biological and psychological process that can be uncomfortable, frightening, and sometimes dangerous without the right care. Recognizing why support matters is crucial. Support reduces risk. Medical supervision can prevent or treat complications. Psychosocial help addresses the root behaviors, and social support reduces isolation that feeds relapse. When withdrawal is treated as a medical and behavioral issue rather than a moral failing, people are more likely to seek help and stick with recovery. That shift in perspective, seeing withdrawal as a treatable condition, changes outcomes. Research consistently shows that integrated support systems lead to higher engagement in treatment and lower rates of relapse and overdose. Concrete examples help make this real. First, consider alcohol withdrawal. In severe cases, it can progress to delirium tremens, a life-threatening state involving hallucinations and seizures. Medically managed detox with benzodiazepines and monitoring can save lives and stabilize patients. Second, opioid withdrawal. Though rarely fatal, causes intense physical pain and cravings that often lead to relapse. Medications like methadone or buprenorphine, combined with counseling, reduce cravings and improve retention in treatment. These are not abstract solutions. They are standard, evidence-based practices used in hospitals and clinics worldwide. Experts emphasize a combined approach. Addiction specialists advocate for medical management to address acute symptoms, while therapists and peer support groups address behavior change and coping skills. Family involvement and community resources further strengthen recovery chances. Yet there are challenges and opposing views. Some argue for abstinence-only models or question medication-assisted treatments, fearing substitution rather than cure. Practical barriers also exist. Limited access to services, stigma, and cost can block care. Understanding withdrawal and why support matters connects directly to the broader recovery journey. It shapes decisions about where and how to seek help, highlights the importance of safety and continuity of care, and underscores that recovery is a supported process, medical, psychological, and social, rather than a solitary act of will. Withdrawal symptoms are the body's physical and psychological reactions when a person reduces or stops using a substance they've become dependent on. They can vary widely depending on the substance: alcohol, opioids, benzodiazepines, nicotine, stimulants, and even some prescription medications all produce distinct patterns, but they generally reflect the brain and body readjusting to the absence of a chemical they had adapted to. Understanding common symptoms and how they show up helps people recognize what's happening and seek appropriate support. Physically, withdrawal often causes headaches, sweating, nausea, tremors, rapid heartbeat, and muscle aches. For example, alcohol withdrawal can lead to tremors, increased heart rate, and in severe cases, seizures or delirium tremens, a life-threatening state with confusion, high fever, and hallucinations. Opioid withdrawal typically produces flu-like symptoms: runny nose, yawning, muscle pain, goosebumps, vomiting, diarrhea, and intense cravings. These physical signs usually start within hours to a few days after the last dose and peak within a few days before gradually subsiding. Psychological symptoms are equally common and sometimes more dangerous. Anxiety, irritability, insomnia, depression, and difficulty concentrating often accompany withdrawal and can trigger relapse. Benzodiazepine withdrawal can cause severe anxiety, panic attacks, perceptual disturbances, and in extreme cases, seizures and psychosis. Stimulant withdrawal, such as from cocaine or amphetamines, may lead to profound fatigue, vivid nightmares, increased appetite, and intense depressive episodes that can include suicidal thoughts. Cravings are a hallmark across many substances. They're powerful urges that can persist long after acute withdrawal ends. Sleep disturbances, whether insomnia or hypersomnia, commonly co-occur and exacerbate emotional instability. Cognitive symptoms, brain fog, slowed thinking, and poor memory make daily tasks harder and contribute to frustration. There are also less obvious manifestations. For nicotine users, withdrawal often presents as heightened appetite and weight gain, along with restlessness and difficulty concentrating. For those stopping certain antidepressants, discontinuation syndrome can cause electric shock sensations, dizziness, and mood swings. Recognizing these symptoms matters because it guides treatment choices. Medical detox can manage severe physical risks like seizures or dehydration, while counseling and medication-assisted treatment can address cravings and mood symptoms. Challenges include variability in symptom timing and intensity, and overlap with co-occurring mental health disorders, which can complicate diagnosis. Alternative viewpoints stress individualized care. Some people do well with gradual tapering, others need structured inpatient support. Linking symptom awareness to appropriate medical and psychosocial interventions increases safety and improves chances for successful recovery. Medical treatments and pharmacological support options are treatments prescribed or supervised by healthcare professionals that use medicines to reduce the intensity of withdrawal symptoms, prevent complications, and improve the chance of a safe, sustained recovery. These options range from short-term symptom relief to longer-term maintenance therapies. The central idea is that brain chemistry and physical dependence change during substance use. Medications help rebalance those systems and ease the body through the acute withdrawal phase, so people can engage in counseling and other supports more effectively. These interventions are important because untreated withdrawal can be dangerous. Severe alcohol or benzodiazepine withdrawal can cause seizures or delirium, while unaddressed opioid withdrawal, though rarely fatal, causes intense cravings and relapse risk. By reducing the physical and psychological distress, medications increase safety and retention in treatment, lower the chance of relapse, and can be tailored to the individual's medical history, the substance involved, and the severity of dependence. Examples include opioid agonist therapies, such as methadone and buprenorphine, which replace illicit opioids and stabilize brain receptors, reducing cravings and preventing withdrawal. Another example is naltrexone, an opioid antagonist used after detoxification to block opioid effects and support abstinence. For alcohol use disorder, benzodiazepines are commonly used in medically supervised detox to prevent seizures and delirium tremens. Longer-term medications like acamprosate and disulfiram can reduce cravings or create aversive responses. For stimulant withdrawal, while no FDA-approved pharmacotherapy exists, off-label use of antidepressants or stimulant replacement in research settings provides symptom relief. Clonidine and lofexidine are non-opioid options that lessen autonomic symptoms, sweating, rapid heart rate, anxiety during opioid withdrawal. Clinician opinions generally favor medication-assisted approaches as part of comprehensive care. Major medical organizations recommend combining pharmacotherapy with counseling and psychosocial supports. However, there are challenges and differing viewpoints. Stigma and the misconception that using medications is simply replacing one drug with another can limit access. Side effects, medication interactions, and the need for careful monitoring, especially with benzodiazepines, methadone, or naltrexone, require medical oversight. Insurance coverage and regulatory barriers can restrict availability, and some patients prefer non-pharmacologic routes. These pharmacological supports are most effective when connected to other aspects of treatment: medical monitoring, behavioral therapy, peer support, and social services. Medication buys time and stability. The full work of recovery typically blends drugs with counseling, relapse prevention planning, and long-term healthcare. Behavioral therapies and psychological interventions are structured approaches that help people manage the emotional, cognitive, and behavioral aspects of withdrawal from substances or addictive behaviors. Rather than focusing on the physical detox alone, these treatments teach practical skills for coping with cravings, identifying triggers, changing unhelpful thought patterns, and rebuilding routines that support recovery. They are delivered by trained therapists in individual, group, or family settings, and can be short-term or part of a longer plan tied to medical care. These interventions matter because withdrawal is rarely just a physical process. Anxiety, depression, sleep disturbance, irritability, intense cravings, and relapse risk are driven by learned habits, maladaptive thinking, and environmental cues. Behavioral therapies reduce the chance of relapse by equipping people with strategies to tolerate distress, reappraise cravings, and replace substance use with healthier behaviors. They also address co-occurring mental health issues that often complicate withdrawal and recovery. Cognitive behavioral therapy, or CBT, is a primary example. CBT helps people recognize the thoughts that trigger use, challenge beliefs like, "I can't cope without this," and practice alternative coping skills such as paced breathing, problem solving, and activity planning. In clinical studies, CBT reduces relapse and improves mood during and after detox. Another widely used approach is motivational interviewing, a collaborative, non-judgmental method that increases motivation to change. It's especially useful at the start of withdrawal when ambivalence is high, helping people commit to treatment and follow through with prescribed supports. Contingency management offers tangible rewards, vouchers, privileges, or small incentives for verified progress like clean drug tests. This method has shown strong short-term success in reducing substance use by reinforcing positive behaviors. Family therapy or couples counseling brings the support network into treatment, improving communication, setting boundaries, and reducing enabling behaviors that can undermine withdrawal efforts. Critiques and challenges exist. Some therapies require trained practitioners and consistent attendance, which can be hard during acute withdrawal. Access barriers, cost, availability, cultural fit, limit reach. Contingency management faces philosophical objections about paying people for abstinence, though evidence supports its effectiveness. Combining behavioral therapies with medication-assisted treatment, peer support groups, and case management often yields the best outcomes. Behavioral and psychological interventions connect directly to medical and social aspects of withdrawal. They complement pharmacological symptom relief, reduce relapse risk, and help rebuild daily functioning and relationships after detox, creating a more durable foundation for long-term recovery.